everyone. So welcome to this very special lecture by Dr. Sameer Avasarala. And for the benefit of few youngsters whom I saw in the list of participants, it is a great privilege to introduce him. Dr. Sameer is an attending physician at the university hospitals and an assistant professor of medicine at Case Western Reserve University School of Medicine. He specializes in minimally invasive diagnostic and therapeutic procedures of the lungs, airways, and the pleural space. He is board certified in internal medicine, pulmonary disease, critical care medicine, and interventional pulmonology. Dr. Avasarala earned his medical degree from India, from the Kamineni Institute of Medical Sciences, which is in Telangana, a state in southern part of India. He completed his residency in internal medicine at Henry Ford Hospital in Detroit, Michigan, where he also served as a chief resident. He then moved over to Cleveland, Ohio in 2017 and completed a pulmonary and critical care medicine fellowship at the Cleveland Clinic, where he served as an instructor in medicine at the Cleveland Clinic Lerner College of Medicine. Before joining university hospitals in 2021, he completed an interventional pulmonology fellowship at Vanderbilt University in Nashville, Tennessee. Dr. Avasarala has a specific research interest in interventional pulmonology. As of 2022, he has published over 20 peer-reviewed journal articles. He has been elected to the steering committee of the interventional procedures section of the American College of Chest Physicians. Additionally, he is an associate editor for the American Association for Bronchology and Interventional Pulmonology podcast. He also serves as a reviewer for the Journal of Bronchology and Interventional Pulmonology. Dr. Avasarala has been awarded the 2022 Chest Young Investigator Grant to research the application of dual energy computed tomography in patients undergoing bronchoscopic lung volume reduction and is the site principal investigator for a multi-centric trial assessing pleural efficient management. As a university hospital interventional pulmonologist, he collaborates closely with the experts in thoracic oncology, otorhinolaryngology, and thoracic surgery at the university hospitals to manage a variety of disease conditions using the latest technological advances in bronchoscopy, including robotic bronchoscopy and bronchoscopic lung volume reduction. Today, he is going to give a fun-filled lecture on the different aspects of CT in pulmonology. And with these very brief words of introduction, let me hand over the stage to Professor Dr. Avasarala to take it forward. Over to you, Dr. Sameer.
Thank you for the warm introduction. It's truly an honor to be here today. I know a lot of people are taking time on a Saturday to listen to this talk, and I appreciate your time up front. So you heard a little bit about me, and today I'm going to talk about a unique intersection between what I do, interventional pulmonology, and a very specific intersection with a radiology, specifically thoracic radiology, and the application of dual energy CT. Before I go further, I do have a few disclosures. I did do some consulting work in recent history for a stent company called Visionaire, and I did receive grant funding from the American College of Chest Physicians. The objectives today will describe the role of what an interventional pulmonologist does. It's still relatively new field, so I want to make sure there's a pretty good understanding. We'll review the current applications of dual energy CT scanning, and we'll outline our active research that we have going on here that involves dual energy CT scanning. So, what does an IP do? I'd like to think when most people hear interventional pulmonology or IP, this is what they think of: rigid bronchoscopy, airway management, debulking tumors, etc. This is what I like to think of what we do. We're a one-stop shop, and it looks more like this, with services from A to Z that involve a very specific part of the body: the lungs, the pleura, and the airway. So to me, interventional pulmonology in a nutshell, we offer minimally invasive diagnostic and therapeutic approaches for both malignant and benign diseases of the airways, the lungs, and pleura. And we do this via a variety of endoscopic or percutaneous procedures. It's very multidisciplinary and contemporary practice. We work hand in hand with thoracic surgery, ENT, radiation oncology, and medical oncology. In addition to that, nothing we do can be done without input and scanning and reports from thoracic radiologists. So I'd like to always think of kind of where we started as a field, and to better understand what IP is all about. My goals today are simple for this part of the talk. Is I'll walk you through kind of where IP started, talk about where we are now, and talk a little bit about the future of interventional pulmonology. So with the history of IP, we'll do a case and evidence-based discussion focused on some examples, highlighting multidisciplinary care coordination between radiology and IP. And we'll specifically highlight ILD, lung nodule sampling, and we'll briefly discuss some things about the future of IP before we start talking about dual energy CT scanning. So I always ask myself when I tune into any talk or attend any meeting and attend a session is, why is this important to me? You may come across a procedure that's applicable to your patient. Worst case, I assure you, you'll see some neat videos. We do a lot of procedures. This is just one chart of several of the things that we can offer for patients. I wouldn't necessarily say one procedure is more important than the other, but kind of keep this in mind as we go through the next set of slides here. So where it all began? So it began some time ago in 1897 with Professor Gustav Killian in Germany. He's credited with doing the first therapeutic rigid bronchoscopy, in which a pork bone was extracted from a farmer in the 60s. He used a rigid esophagus scope at the time with the use of rigid forceps. Crossing the pond here to the United States, Chevalier Jackson was the first to perform rigid bronchoscopy in the US. Through his storied career, it's reported that he took out around 2,000 foreign body extractions. And because of the work he was doing, foreign body airway obstruction mortality rate dropped from 98 to 2%. Fast forward several decades, and this gentleman, Dr. Shigeto Akita, is credited with being the father of fiber optic bronchoscopy and developed the first flexible bronchoscope in the 1960s. Coming to the 1980s, there's been descriptions of using YAG laser within rigid bronchoscopy. And this refinement of using laser to get rid of and manage central airway obstruction is really credited to Dr. Dumont, who is widely considered as the father of interventional pulmonary. In 1990, he published one of the first series describing 188 prosthesis implants. These are tracheobronchial prosthesis in 66 patients using his special stent that we still use today, the Dumont silicone stent. Later on, I would say this is the next milestone in interventional pulmonology with Dr. Kazu Yasufuku, who's a thoracic surgeon who is credited with inventing and perfecting the use of the linear endobronchial ultrasound. This was the first report published in 2004, which included 70 patients. This is an important milestone since prior to this, mediastinoscopy was the way to go. And right now, mediastinoscopy is only considered if EBIS-TBNA can't be done or EBIS-TBNA did not provide the answers that one was expecting. He's a thoracic surgeon at Toronto General. So this is one of the things that I love about IP, and it's collaboration. And one of the most important aspects and things about my job that happen every day is this collaboration between interventional pulmonology and radiology. Yeah, I'd like to think at the intersection of that collaboration is how we provide excellent care for our patients. I'd like to walk you folks through a few examples of how we do this. And I think some of the best examples are highlighting cases with interstitial lung diseases and also lung nodule management. So shifting gears slightly to ILD, I'm sure most of you are involved in MDD meetings that include thoracic radiology, thoracic surgery, interventional pulmonology, and pulmonologists about how to manage this particular patient group. So as we know, it's a heterogeneous group of disorders that frequently represent a diagnostic challenge for clinicians. MDD is really the way to go to reach a consensus diagnosis, so these patients are on appropriate therapy. It's been proven that histology is not always required with advances in CT imaging and consensus recommendations. It's possible to make the diagnosis based on CT patterns of how the lung parenchyma is looking. But when a biopsy is necessary, different approaches can be considered, and it's not a one size fits all approach. Since about 2009, transbronchial cryobiopsy, it's become an attractive, minimally invasive option for the evaluation of ILD. It lets us get bigger pieces of tissue when you compare to traditional transbronchial biopsies. Additionally, since we use a cryoprobe, we avoid having the issue of any crush artifact. In the past, the multidisciplinary IPF clinical practice guidelines suggested that SLP could be avoided in a significant amount of cases by performing transbronchial cryobiopsy. But at the time, there was not procedural standardization, and because the little bit of data that was out there across mixed results across different institutions, they couldn't make a recommendation either for or against doing transbronchial cryobiopsies for patients with interstitial lung disease. Later on in 2020, the American College of Chest Physicians, their expert panel report, they concluded that transbronchial biopsy is a reasonable alternative for surgical lung biopsy for providing histology for ILD MDD. Several pieces of research have looked into this. Systematic reviews and meta-analysis suggest that transbronchial biopsy has a fairly good diagnostic yield. And looking at these studies right here, it ranges from 72.9 to 81%. The main goal of transbronchial biopsies is simple. It's to get enough tissue and minimize harm to the patient. I think that sounds great, but anytime a new or relatively new procedure is considered, I always ask myself, well, how's it compare to the gold standard? And in this instance, the gold standard is a surgical lung biopsy in a specific group of patients in which radiography did not give the answer to. So a lot of studies in the past have looked into this particular question. This is a summary table of those, and you can see they're grouped into 2 retrospective and 2 prospective studies. I'm going to focus on the prospective studies now. The one published by Romagnoli that was published in the Blue Journal in 2019, it was prospective, multi-center, 2 centers to be exact, study that suggested poor concordance between transbronchial cryobiopsy and surgical lung biopsy. This kind of took the air out of doing this, since when it was compared to the gold standard, they found that not much agreement, 38% to be exact. Some criticism for the study, the use of a single histopathologist who was blinded to the clinical data, but they were not a participant in the MDD. It substantially limited the interpretation of this data. Later on, the cold eye study published by Troy et al. Showed that the raw agreement was much better, specifically around 71% or so. It kind of refuted the previous study findings. And this is because there was better incorporation of the MDD. And once that was put into place, you're looking at agreements around 77%. So later on, several years later, it's been looked into again. This particular study that was published in Annals of the American Thoracic Society in 2020 looked into cryobiopsies for the diagnosis of HP among patients with interstitial lung disease. It looked into seeing how many more transbronchial cryobiopsies, how much more use they would be over transbronchial biopsies. In this, it showed that there was 82% diagnosis with transbronchial cryobiopsies when compared to transbronchial biopsies, which is using standard forceps, was only 37%. When you're comparing the 2 groups for complications and the traditional transbronchial forceps biopsies, as far as moderate to severe bleeding and pneumothorax, it was 4, 0, and 7%. When looking at the transbronchial cryobiopsy group, the numbers weren't much different. It's 11%, 0%, and 11%. So overall, they concluded it's low quality evidence, but the needle was tilting more towards transbronchial cryobiopsies can be very useful in these patients suspected to have the hypersensitivity pneumonitis subtype of interstitial lung disease. I'd like to show a short video of how this kind of works, and there are several approaches to doing transbronchial cryobiopsies. This is one using a rigid bronchoscope. Here, the airway secured in our patient with the rigid bronchoscope, and a flexible bronchoscope is being used as well. We have the fluoro machine there. That's me. By this time, I have the fluoroscopy there, the rigid's in. You can see the probe there that's kind of rounded at the distal end. We try to feel the pleura, come back about 1 centimeter, freeze for several seconds, and do a rapid pull. Once I'm doing the rapid pull at the bottom right, you can see The blue structure is the cryoprobe. And then once that sample is out, I inflate the balloon to tampen out that area so there's not soiling. And if there is bleeding, it's controlled and blocked off into that particular area. We do this several times to get enough tissue. The main things we worry about during this procedure is respiratory failure. We know these patients don't have normal lungs to begin with. Bleeding, since we are acquiring fairly large tissue samples when compared to forceps biopsies, and also pneumothorax. That's the standard scope going back into that particular area. That being said, with transbronchial cryobiopsies, although the temperatures are cool, it's a very hot topic in ILD. I'm no way endorsing that it's the way to go with the current body of data, but it's up for discussion. And in the setting of using a MDD, I think it's a useful thing to consider. Next, I'd like to touch a little bit upon lung nodules, another very specific intersection between thoracic radiology and also interventional pulmonology. So estimates suggest that anywhere between 60 to 80 million CT scans are performed in the United States on an annual basis. Those same estimates suggest that 10 to 12 million of those are CT scans of the chest. You can imagine lots of incidental findings, including lung nodules too. The lung nodules that give us the most trouble are peripheral pulmonary lesions, which are ones that are less than 3 centimeters in the periphery. They're often very challenging to biopsy with conventional flexible bronchoscopy. And once a decision is made to do a biopsy based on kind of pretest probability of this being malignancy, we have to start talking about which approaches we can use to get the diagnosis in a safe way. To kind of put this in a schematic manner, this is kind of what I'm talking about here with the peripheral lung lesions. We're not talking about the central part that's adjacent to the airway. We're talking about closer to the pleura, smaller, more difficult to reach. In addition to the CT scans that are being done and these incidentals being picked up, or these things that are being followed, the advent of low-dose chest CT will also inherently increase the amount of nodules that are found. By all means, at this time, low-dose chest CT screening could certainly be better in the United States. They estimate it's around 6%, and depending on the states you look at, it can be as low as 1%. But this is certainly going to continue to add to the pool of the number of lung nodules that we at least need to monitor via CT. And I'm sure a significant proportion of those will end up getting biopsied, or at least going to surgery and getting a tissue sample in one way or another. So to kind of walk through a prototypical example of what comes across my clinic, the 56-year-old woman, fairly significant severe COPD with an FEV1 of 25%, several comorbidities, hypertension, CKD, found to have a 2.3 centimeter right upper lobe nodule on CT. It's spiculated, so it looks worrisome. This was an incidental finding. She presented to the ED for issues with chest pain and trouble breathing, so she had a CT chest angio done. She's asymptomatic and quit smoking about a month ago, but has a 60-pack year history. A historical CT 3 months ago showed that the nodule has increased in size, and reviewing those images, there's no associated lymphadenopathy. This is what an example of that would look like. I wouldn't say it's small by any means. We have an airway going right through it. Depending on how you kind of parse out your pretest probability, one of the ones that I use fairly frequently is a Mayo Clinic prediction model. This seems to be around 50%. Due to her FEV1, she's not a surgical candidate, and rightfully so. Radiation oncology would prefer not to give her empiric radiation without a tissue diagnosis. Plus, if we're going down the route of radiation, we'd like to make sure that her lymph nodes are clear, and a good way we can do that is EBIS-TBNA. So how do we get to this thing? I think this particular lesion had an airway going right to it. So I suspect that we likely could have gotten to it fishing around with either an extended working channel or a guide sheath using radioprobe ultrasound and fluoroscopy. But it's been proven in and out that navigational bronchoscopy has a higher diagnostic yield when compared to conventional bronchoscopy. The ACCP, or CHEST, does recommend using ENB to reach these lesions where there's available equipment and expertise, and this is from 2013. Some facts to keep in mind, again, when something like this comes up, I also ask myself, where is the data? And this has been looked into. This study was published by Nicole Tanner and her group in CHEST in 2018. It was a multi-center prospective randomized control trial where they compared standard bronchoscopy with fluoro versus thin bronchoscopy at the radioprobe endobronchial ultrasound for lesions of for biopsy of pulmonary lesions. So none of these were incorporating electromagnetic navigation bronchoscopy. The group crossed over from standard to the thin bronchoscopy if it was non-diagnostic. In summary, underwhelming diagnostic yield in the two groups and not statistically significant, 37%, so worse than a coin toss, and 49%, again, worse than a coin toss for both groups. So by the time this study was published, the specific question they were answering, we didn't have a good way to reach these samples without using something else. These are examples of that something else. In current practice, my classification is to split them into two. For guided bronchoscopy, you have your non-robotic platforms, which include SuperDimension, Illumicite, your spin thoracic navigation system, and Archimedes, and your robotic bronchoscopy, which is the hot new thing, the interventional pulmonary and diagnostic bronchoscopy. The Monarch platform, Ion, and Galaxy. I cover all of these to some degree in the next few slides. SuperDimension is what I'd like to consider our tried and true. It's been around since around 2004. The time of its heyday, it was the most widely used E&B platform and it had about 90% market share. It's tough to say that with certainty these days. It's definitely the most studied E&B platform. And the largest study we have about this was a Navigate study published in 2019 in JTO. Over 1,000 patients across 29 centers in the United States, which was a mix of academic and community-based healthcare facilities. They did cap enrollment in each site to around 75, so they can get a heterogeneous mix of patients. And in simplicity, patients with peripheral lung lesions undergoing E&B were included in the study. Almost half the lesions were less than 2 centimeters in size. A majority of them were in the upper lobes. Median distance from the pleural was less than 1 centimeter. And successful navigation and tissue acquisition was around 95%. I want to emphasize that that does not translate to diagnostic yield. That was just the ability to get to the spot and get tissue in the area that they wanted to get from. 12-month diagnostic yield was around 73%, and sensitivity at 12 months for malignancy was around 69%. Fairly low rate of complications. Pneumothorax was around 4.3%. Serious bleeding was 1.5%, and respiratory failure was very low at 0.4%. No study is perfect. The limitations of this study were that it was single arm, non-randomized, definitely a patient selection bias, and the inability to generalize the results because they only included operators who would do at least 5 E&B cases per month. This is not the only study that's out there about the SuperDimension platform. This is just a table of some of the studies that were published, and depending on how you define diagnostic yield, things can be as low as 38.5% or high as around 97%. And that's a different question. It comes down to how we define diagnostic yield. Getting to more advancements on electromagnetic navigation is fluoroscopic navigation. This really helps correct for a problem that we run into every day, which is CT to body divergence. In simplicity, that means the CT that we use to plan the route we like to take to get to access the spot on the patient is not what's going on in the patient that's on the table after they had general anesthesia and they've been induced and now have an endotracheal tube. With fluoroscopic navigation, it incorporates digital tomosynthesis to read, register the target during the procedure. Think of it as a kind of a GPS update. One of the first systems to use this was a SuperD system with the FluoroNav upgrade. A study by Abudara et al. That was published in Respiration 2020 showed that a diagnostic yield of 79% over 177 nodules when compared to using traditional SuperDimension. And that same or similar patient population was 54%. This is kind of what that looks like. We get to the area, we mark the spot, and then we do a spin with the fluoro system. We kind of remark the spot there, and then the system corrects and gives us an updated target. This has been looked at again in a different study. This was 324 patients and 363 nodules were sampled. The average nodule size was around 1.9 centimeters in this. Around 83% of patients or nodules that were sampled had lesional findings. So overall, fairly good diagnostic yield for smaller nodules. The next version of this is Illumicite. It also uses digital tomosynthesis. The upgrade is that there's sensors at the end of the tip of the working channel. So you're always able to track to some degree. This is us in a simulated nodule. That's a tool kind of going out there. It's a triple needle brush sampling the area. We've also published on this as well. This was the initial report of the leukocyte with the first 100 nodules or first 100 lesions that were sampled. Overall diagnostic yield was 79%. If you look at the group that we did the digital tomosynthesis sweep on, the diagnostic yield was 83%. Low pneumothorax rate, 3%, and bleeding requiring intervention was also low at 2%. Now to I would say the latest technology in sampling these peripheral nodules, robotic assisted bronchoscopy. The main advantage of these platforms is precision control in the periphery. Right now, there's two systems that are freely available. Oh, freely is the wrong word to use, that are available on the market, which is the Monarch by Auris Health and now J&J, and the Ion by Intuitive Surgical. There's another system, a Galaxy, which should be coming out soon. I'll talk a little bit more about that, but you can't purchase it now if you wanted to. The Monarch system was approved by the FDA in 2018. One of the first studies that published about this sampled 15 parenchymal lesions. Malignant diagnoses were found in 9 of these patients. In a cadaveric model, they sampled 77 nodules. 77 nodules, my apologies, and had a diagnosis of 97%. This is what the system looked like. It has 2 really neat looking robotic arms that come out and extend. It's controlled by the controller that you see on the console, which was designed after the Xbox controller. This is a system that we have at my shop. This is one example of me using this to get diagnostic tissue on a person which is suspicious nodule. Typically, we do this procedure and it's immediately followed by a staging EBUS tube. The largest study that's been published using the Monarch platform is at this one at a University of Chicago, in which they looked at a good amount of lesions. The median size was about 20.5 millimeters or so, and their 12-month diagnostic yield was reported to be 77%. In this study, they attempted 124 robotic assisted bronchoscopies. The Ion platform by Intuitive, it does not use electromagnetic navigation. The Monarch does. This uses a specific technology called shape sensing. It's a fully articulating 3.5 OD catheter. It's used to access these nodules, and the working channel is about 8, 180-degree rotation in all directions. The initial study of 29 patients show that we're able to get to the area in about 97% of cases, and the diagnostic yield around 80%. Lesions are really small in this initial study, around 12.5 or so. And then this adds difficulty when there's not a bronchus sign. And of note, around 42% of these lesions did not have a bronchus sign going to it. And this is what the Ion platform looks like. As of now, the largest body of data published on the Ion system is this study that was published in Chest in February of 2022. This came out of Memorial Sloan Kettering. 159 pulmonary lesions were targeted in 131 procedures. Median lesion size was 18 millimeters, and the overall diagnostic yield was really good, 81.7%. Overall complication rate was low, quoted to be 3%, and the pneumothorax rate was 1.5%. This is the newest player in the robotic assisted bronchoscopy field. This is the Galaxy system that has been developed by Noah Med. It's a robotic platform that incorporates digital tomosynthesis and some other techs that are touted to be advantages. I say touted because the initial in human studies are not out about this, and people are looking into it now. They did do some studies looking at how this works in pig models, and in this study that was published, 4 very experienced interventional pulmonary doctors perform biopsies in pig models, 20 nodules each, 20 simulated nodules total, excuse me. The average lesion size was fairly small, 16 millimeters or so, and tooling lesion success rate was 95%. Tooling lesion is defined as you get to the area, you put your tool into the target zone and do some sort of imaging to confirm that the tool is there. Like I said, this system is fairly new. It received FDA clearance not too long ago, March 2023, to be exact. There is in-human studies going on now. specifically in Sydney, Australia, at Macquarie University, right there. We'll see how this plans out. It seems like it's a really nice complement of robotic-assisted bronchoscopy with digital tomosynthesis as well. Also, in newer technologies, cone beam CT, y'all may be very familiar with this. It's an imaging modality that's not infrequently used in the field of interventional radiology. We can incorporate this into bronchoscopy with rotation of the arm. It was first used in peripheral bronchoscopy, so it is, I would say, still relatively novel. And one of the first series was published in 2014. The real advantage of this is we can make corrections, and it's a true representation of what's going on with the patient right in front of you, instead of using a scan that clearly has been taken prior to them going under general anesthesia. A study that paired CBCT within an ultrasound bronchoscopy showed a diagnostic yield of 70%. Please keep in mind that this study is from 2018, and we've made several technological advances since that point. This is kind of what cone beam CT looks like in the realm of bronchoscopy. We have a patient on the table. The scope is in. That's an electromagnetic navigation system being used. We got to the area we needed to, and then what we do is the spin, and then use different software packages to kind of mark where the lesion truly is, and do an overlay on the screen and try to make adjustments with the bronchoscope to really try to get the tool into the lesion. Now, all of that's great, but what's next as far as the future of IP is concerned? And this is what continuously keeps me excited about what we're going to be doing in the future. This received FDA breakthrough designation in 2019. It's bronchial rheoplasty, in which pulse electrical fields get delivered to the airway epithelium and mucosa. It causes cell death by disrupting homeostasis, leading to osmotic swelling and apoptosis. It doesn't destroy architectural function of the tissue, so this is being looked into for patients with chronic bronchitis. This is another study about what may be coming up. This was published in 2019 using rigid bronchoscopy, using a specific concentric tube robot system, in which they studied this new system, and there's reduction in central airway obstruction, and also the reduction of force applied to the patient's head and neck. Rigid bronchoscopy, in simplicity, is a stainless steel metal tube that goes into patients. So we have to make sure their neck is somewhat movable, so we can get in there without causing any additional trauma to their neck and also their soft tissues or teeth, etc. This is another point that a lot of interventional pulmonology is very excited about, using guided techniques in the periphery to ablate peripheral lung tumors. This is just one example of some early results. This was particularly looking at patients with oligometastatic disease who underwent bronchoscopic microwave ablation. Not a large report. It was just 4 lung lesions. More recently, research is being conducted in this. This just came out April 4th in 2023. This particular study is looking into using microwave ablation for oligometastatic disease. So in summary, I think interventional pulmonology does a very bright future, but patient selection and incorporation of advanced imaging tools are the keys to the advancements of the field. So this is a great segue with advanced imaging tools to allow me to talk about dual energy CT scans. I think this is the part of the talk I was most nervous about, talking about imaging modalities to a group that's very likely a majority radiologists. So this particular technology has been available since the mid-2000s. In simplicity, secondary energy is used to differentiate two materials, which allows for improved attenuation. The highlighted text I grabbed from a great review article that explains dual energy CT in a very, very succinct form. We have this at our current institutions, and we use it from time to time. I'll talk about the applications in the next few slides. This is the system that we have. It's a Siemens Somatom definition flash. It's a dual source CT scanner, and that means 2 X-ray sources and 2 data acquisition systems are used. They're mounted on the same gantry and positioned orthogonally to one another. This is a schema of what this looks like. I pulled this from that same very, very useful review article. Just to recap some of the history of where dual source CT scanners and dual energy CTs come from, introduced in 2006. And then 2009, the next version came out, and then 2013, the Somatom Force. All of these particular models are all by the same company, Siemens Healthineers, based out of Germany. So I'm biased, but I believe this is great tech, and I'd like to talk a little bit about the clinical applications of this. We'll start off with ways that they're used outside of interventional pulmonology. Then I'll finish with how we're using it to help us with patients with lung disease and some of the research that we're doing here. It does have applications with CT angiography. One of the biggest applications is bone can be removed, which allows direct visualization of iodinated blood vessels. This is, again, a nice representative picture on the left side with bones in place. And once those are reviewed, you can get an excellent view of what the vessels look like. Similarly, like bone, plaques can be removed from the vessels, which allows clearer visualization of the vascular lumens, which can be very useful for those working on the vascular side of things, whether you're an interventional cardiologist specializing in peripheral procedures, vascular surgeon, or interventional radiologist doing procedures on the vasculature. This is an example image of a patient with fairly significant calcification. And once dual energy CT scanning and computer algorithms are incorporated and those are removed, you can see that there's areas in which the lumens are actually compromised as well. Another great application is to construct virtual non-calcium images. Calcium can be identified and removed. We talked about this already. This, in addition to just getting rid of the bone, it can also improve with enhanced visualization of the underlying soft tissue and detection of bone marrow edema. This is the application of that in a patient who sustained an injury and bone bruises. This is a 29-year-old male soccer player. This is a corresponding MRI to it. So it does provide useful information, which can be supplemented by the MRI, but may be missed on traditional CT scanners. Other non-pulmonary uses and multiple case series and reports are out about them is urinary stone characterization. Custom software can help delineate and color code the type of stone, whether it's uric acid, calcium oxalate, or apatate. The similar concepts can be used for crystalline arthropathies to differentiate gout from pseudogout. And there's also some reports out there about how it can be used to help clearly differentiate regions of silicone from surrounding breast tissue when there's concerns from silicone breast implant leaks. So let's talk about the pulmonary application of dual energy CT now. I think one of the most important applications is using and leveraging how we can incorporate assessment of perfusion and blood volume. You can identify iodine voxels and allow for a color enhancement of iodinated areas. This is really, really good for assessing perfusion defects in the lungs. I know I said we talk about lungs, but the same principle can be applied to areas of ischemia in the myocardium. This is one example of what that looks like. This is a 31-year-old male who had a PE affecting vasculature in the right lower lobe. And you can see that most of the lung is a really nice looking red. And then in the right lower lobe, you can see the area of defects. This has been studied several times and published from our group here. These are my colleagues at university hospitals, and they put this study out in the Blue Journal, or a case report out in the Blue Journal. This is a 29-year-old woman who was admitted to the ICU for severe hypoxic respiratory failure, had a history of polysubstance abuse. She had an initial contrast-enhanced CT done because PE was in the differential. It was a suspicion for aspiration bronchiolitis, but things weren't adding up as far as why the lung parenchyma was so clear, there was no PE detected, and why she was so hypoxic. Because the examination was performed on a dual energy CT system, additional reconstructions were done with iodine density mapping. And you can see in panel C and D that there's areas of pulmonary vasoconstriction going on. Excuse me, let me go back to that. And this is a homeostatic mechanism that occurs with the lung that allows shunting and things like that. We provided good supportive care, and I think she was extubated shortly after. So this is a good implementation of how this technology can be used to make sure other investigations or potentially procedures that may not have been effective for this patient are avoided. Again, virtual non-contrast enhanced images is another thing that can be used. or another principle that can be leveraged with dual energy CTs. The iodine voxels are identified and the component of the CT is removed and a virtual non-contrast image is created. So this is very useful in the world of urology. When kidneys, ureters, and bladders are imaged, typically you need contrast and non-contrast CT scans, but the non-contrast is really used for visualizations of the stones. And this similar concept, we're looking into using it in the pulmonary world for patients undergoing bronchoscopic lung volume reduction. And we can use a virtual non-contrast CT to potentially see if we can do Fisher analysis in patients who have undergone bronchoscopic lung volume reduction. We're still working out the intricacies of that one. Shifting gears from perfusion a bit, very useful lung nodule assessment. This is also another case report published by my colleagues here at University Hospitals. This is a 73-year-old male former smoker with a 50-pack-year history, also had hypertension and hyperlipidemia, with lung nodules that were incidentally detected on a CT scan. You can see the right upper lobe lung nodule and the right lower lobe lung nodule marked by the arrows there. So this person did have a contrast enhanced CT. Iodine maps were constructed, and you can see that there's definitely differences in densities for these two particular lesions. One being higher at 2.5 milligrams per milliliter and one being much lower at 0.5 milligrams per milliliter. So one clearly looked more concerning than the other. A biopsy did confirm poorly differentiated squamous cell and one of the lesions, the one with the 2.5 milligrams per milliliter. This was done by ctDNA. The patient also had a PET scan done, which showed similar findings, and a staging endobronchial ultrasound. The right middle lobe nodule was poorly differentiated squamous T2A N0 M0, and the right upper lobe was a benign necrotizing granuloma. This patient had severe emphysema with a reduced FEV1 and also a reduced DLCO, deemed not to be a good surgical candidate. Again, the CT scan that was already done was reformatted, different software was used to figure out a perfusion mapping, which came out to be this particular breakdown. And the reason I want to share this case is the use of dual energy CT scans as a whole in one setting can provide information of the characterization of lung nodules and the assessment of lung function and realms of perfusion in a single examination. This is the same case. This came out to be a granuloma. This came out to be the adenocarcinoma. This is the particular case report for the patient I just went through. Another example, a 70-year-old female patient with a history of smoking, 80 pack years, again, incidental nodules, and was referred for a contrast enhanced CT scan, had a right upper node nodule that was 13 by 15, 71 Hounsfield units, 2.1 mg per ml uptake, iodine uptake, and a left upper lobe nodule, which was slightly bigger, 44 HU, but much less iodine uptake on the maps. Concordant findings were obtained on a PET scan that was done with low hypermetabolic activity in the left pulmonary nodule and a much more higher metabolic activity in the right-sided nodule with the SUV of 7.1. These are the representative pictures in this particular case report that was published, again, from the same group here. So those are some of the examples in which we have used dual energy CT scanning to provide the best care we can for our patients in the realm of assessing vasoconstriction of the pulmonary vasculature, and then also lung nodules. From the lung nodule standpoint, we see a lot of these. I live in the histobelt of the United States, so not every nodule is malignant. And this is just another tool that we can use in further research to see how we can better quantify what needs to be done for these patients, running the spectrum from just follow-up imaging to something as invasive as this needs to be cut out because the pretest probability is so high. I'd like to conclude with talking about our current research that we're doing here involving dual energy CT scanning and also interventional pulmonology. It's lung volume reduction by dual energy CT, the Luminance study. I'm the principal investigator for the study. We're grant supported by American College of Chest Physicians. That's the clinical trials identifier right there. So bronchoscopic lung volume reduction gives us the advantage of providing a minimally invasive option for patients with bad emphysema who are on maximal medical therapy and still very symptomatic, who either can't or don't want to get lung transplant, or can't or don't want to undergo surgical lung volume reduction. These one-way valves can be placed bronchoscopically. Patient selection is very key, and before they get onto the table for assessment of these valves can place, they go through a variety of tests, which take days and sometimes weeks to get done based on scheduling availability from the patient and also from our standpoint, and includes perfusion assessment and CT scans as well. One of the newer notions in bronchoscopic lung volume reduction is to target the lobes of the lung that are receiving the least blood flow or the most diseased lungs, because those areas are thought to have the most pulmonary vasoconstriction related. The point of this procedure is to allow less disease or more healthy lung to take up more space and allow for some symptomatic relief, which can be measured by the patient being able to walk further. These are how the valves are deployed. And then what we're doing in this particular study is to use dual energy CT scanning to really identify the areas that are most hypoperfused. So the patients get these studies done pre-valve and also around their 8-week post-valve period. And we'll be comparing the results to their perfusion studies or traditional nuclear medicine-based perfusion studies that were done on the pre-valve assessment, which at our program is the standard of care. And the goal of this is if we can prove that the dual energy CT scanning perfusion mapping is spitting out the same information in the future, it's possible that the patients can avoid getting that special nuclear medicine-based perfusion scan done, since they're going to have to go to get a CT scan no matter what for planning of the valve procedure. That's the thought. We have enrolled 2 patients thus far. The study just started, hoping that we can reach our enrollment target within the next 12 to 16 months. So my take-home points: IP is a very exciting, relatively new field, which offers minimally invasive diagnostic and therapeutic procedures. As I mentioned, of the lungs, airways, and pleural space, the envelope continues to be pushed in diagnostic and therapeutics. Dual energy CT scanning has many applications. Most use in IP is within characterization of lung nodules and assessing pulmonary perfusion. And bronchoscopic lung volume reduction can be very helpful in the right patient with emphysema. Dual energy CT scanning may be useful in target lobe selection. I'd like to certainly give a special thanks to Dr. Amit Gupta. He's one of our expert thoracic radiologists and our dual energy CT champion here. He's an associate professor here at Case, and I wouldn't be able to conduct any of the research related to DECT without his mentorship. A lot of the presentation had in-text citations. These were footnote references from the presentation, if you'd like to refer to them. And these are the references from the images. At this point, this concludes my presentation. I appreciate the privilege of your time, and I'm happy to take any questions y'all may have. Thanks.
Thanks, Samir. That was an excellent talk, very energetic and full of information. And yes, there are questions. They are posted in the chat. So there's a question. There are actually 3 questions. I'll read them one by one for you. Cone beam CT, what's the success rate quoted for peripheral 1 centimeter nodules?
Yeah, so it comes down to how we define diagnostic yield. So with cone beam CT, one of the things that we're shifting towards is success is measured by, can I visualize the tool in the lesion? So I think that's good radiographic success, but in the end, it doesn't matter to the patient. The patient does not care that you put a needle or forceps into their nodule. They care if your procedure led to a change in their management or treatment plan. Did I get a diagnosis? So I would say with the case series that are out there, depending on what adjunct technology you're using, whether that's standard bronchoscopy, using a guide sheath or extended working channel, or more advanced things, and there have been reports of combining robotic systems, specifically the Ion and even the Monarch, and using cone beam CT on top of that. So the tool-in lesion success rate is quite high. We're talking 95, 90%. So, and it's going to vary a little bit depending on what study you look at. But the diagnostic yield is capping around 80 to 85%, but I want to emphasize that everyone really should look into how that particular study defined diagnostic yield, because I may do a study where atypical cells are considered non-diagnostic, and another person may do a study in which atypical cells are considered diagnostic. So those nuances are important.
Thank you. So the second question from Nareen is, what's the incidence of air embolism in transbronchial biopsies?
That's a good question. I don't think I've ever come across an air embolism with transbronchial cryobiopsies. The times that embolism can be within on the radar of could this occur is sometimes when I do therapeutic procedures, I use argon plasma coagulation, which uses a flow of argon gas, and you can get an argon gas embolism, which is very rare but catastrophic. But I have not ran into air embolism with transbronchial biopsies.
Yep. And the third question is, DECT versus photon counting. What will be your preference if you have both?
That's an interesting question. We've had multiple conversations with the thoracic radiology group. Last I heard, we were working on getting our hands on the latter technology. So I don't have any personal experience with it, but once we get it, I'd love to get some sort of series going and looking at the differences between PET scanning, dual energy CT, and photon counting about what provides the most useful information about these suspicious lung nodules.
Thank you. Is there any other questions? I'm sure people are thinking about that.
Hey, great talk, Dr. Samir. This is Amol, one of the nuclear medicine physicians at Emory. Interesting thing. So my query is and this may be more of a radiology question than a IP question, but I want to know if there is a way of standardizing these things, because for dual energy CT, the way it's implemented in different institutes, there are differences in acquisition techniques, image reconstruction methods, post-processing methods. And so the values you presented may not be similar if the study is repeated, say, across town from Cleveland to make another institute.
Sure.
And so for this to be more universally implemented in the US, you need to standardize things, and was curious because we face that problem a lot in PET imaging. There's so much differences in the way the protocols are implemented. The scanner are different qualities. And so SUVs may not mean the same if it's done on a different scanner. And I think dual energy CT has a similar issue of standardization, because on a single energy CT, the Hounsfield units are pretty standard, but for dual energy, all those values are different. So any thoughts on that?
Yeah, well, I think you underscored why I'm so happy that I work with very, very smart radiologists. To your point, to build upon that more, I've trained at different institutions through my career, and till the point I came here, I've never even heard of dual energy CT scanning. So I think there's also some, and you can correct me if I'm wrong, bias about who has specific research interests in said particular institution and how much they implement dual energy CT scans for their particular clinical practice. And some of that may have to do with lack of standardization. And I guess within the realm of thoracic radiology and other institutions, is it something that's being looked into at most places? I'm going to claim, like I said, a bit of ignorance because I've never heard of it before coming to UH.
So it's different across different institutions, and also not all radiologists are trained in dual energy or comfortable implementing dual energy, and not a lot of referring physicians are aware of it. And so if there's no, it's kind of a little bit of a supply demand and knowledge of ignorance situation. So if there's no demand from the referring physicians, radiologists are already overworked, so they're not going to go out of the way to do these kind of things. So it's a little bit of onus on you guys as well to talk with radiology and tell them, hey, this is something that I've heard at conferences. Can we implement this at our institution? And then the radiology department will be kind of like, okay, we need to do this kind of a thing. But I'm curious because there are so many different CT scanners and ways of doing things, that how you're going to standardize it? Because we're still struggling for PET. It's been 10, 15 years now that PET is now almost universal in workup of malignancies. But not only is it not standardized, the advances in scanner technology is also an issue with standardizing protocols. And so and as CT technology is rapidly developing as well. So with photon counting and all those things, it's going to be interesting how things play out.
So Amol, this is Narendra here. So if I can intervene and speak as a radiologist kind of thing, because there's not much established dual energy CT. So there is only very few fields where it is well established. So standardizing protocols for dual energy CT is a very, very challenging task because there is not much established indications for dual energy CT. It's still, it's on the horizon to the last 10 years approximately, but still, people are trying to find, what dual energy has the advantages over the normal CT, monoenergetic CTs. So that's why once it gets established, then probably it would be better to take care to standardize the protocols for DECT. And as the dual photon, photon energy counting becomes more and more available and gets cheaper. So right now it's out of bounds for most of the institutions, 3 million for a stock basic photon counting CT scanner. Then probably dual energy would fade out, in my opinion. When it gets CT photon counting, maybe in the realm of 1 million or so, then probably dual energy CT is going to fade out. So that's my personal opinion. So there's no, and this is anecdotal answer to your question.
Thank you.
Thanks, Guptaji. Good to see you here.
Yeah, good to see you, Amol.
Any more queries? So,
That was a brilliant talk, Samir. I enjoyed it thoroughly. I keep my Saturdays for the golf morning, but I particularly made sure, I attend this lecture. Thank you.
Well, I hope you get to make it to the course later today. I appreciate your time.
Thanks a lot. Thanks. Bye.
absolutely scintillating lecture. And I think, yeah. So I would like to, Jyotsna, you had something?
Yeah. Thanks a lot, Samir, for the illuminating talk. Hope to hear you in the future again.
I hope so too.
Yeah. Okay. Thanks again. Yeah.
Thank you. I think on behalf of everyone here, thank you for that wonderful lecture. And I'm sure that we'll get more opportunities to discuss more about not just only about different modalities of CT, but also how this artificial intelligence and image processing, deep learning is actually helping us more on these, adding to all these complexities and additional layers. Thank you very much, Samir. It was definitely, I'm not a medical practitioner, but it was definitely very, very illuminating. Thank you. And thank you all for sparing your time and being part of this discussion, I would say. Thank you very much.
Thanks, folks.
Thanks all. Bye.
Bye-bye. Bye-bye.